someone down or giving them some down. They're less agitated, they might be a bit sleepy, but they are able, and most times the line we use is them being able to support their airway if they're sedated. Once they're beyond that, then they're deeply sedated. Then hypnosis is really forcing you to sleep, because it's not you choosing to sleep. It's putting you to sleep, which is what we're doing in theater when you put them completely to sleep and give them a general anesthetic. That's hypnosis. Okay. So intravenous anesthetics are used, you're going to see them cut across. We'll use them in theater, you'll use them in the ICUs, you'll use them on the wards, you'll use them in what we call remote anesthesia, for instance, sedation during endoscopy in endoscopic units, or if you've seen down in radiology, sometimes for the children, they'll need to be sedated. So that's where you see the sedation in the ICU. Then sometimes it's the only drug in endoscopic units. Then what we call monitored anesthesia care is really where you give only sedative drugs. You use a combination of drugs to be able to achieve a certain level of calmness and also different characteristics. Then also induction, as we've seen or we'll see, and then maintenance of anesthesia. Those are the principal users for most of these drugs. Some of them have analgesic properties as well. So looking at when you're going to look at these drugs, what we'll start with the pharmacodynamics and the pharmacokinetics. So pharmacokinetics, as we all know, it's what the body does to the drug. So you give a drug intravenous, you have what we call brain circulation, because most of these drugs, or all of these drugs that we are using, are going to go and act on some part of the brain. So you have it in through the vein, gets into your heart, circulates, gets to the brain. So you have the peak. This is just a recap of pharmacology, which I believe everyone should be able to remember. Then you have it getting into the system, going to the brain. You have your effects, and then depending on its lipid solubility, will be redistributed to the other parts of the body, whether to fat, or when it comes into plasma, it's broken down and all that. Then it's metabolized. Some are metabolized in blood by the different enzymes within the plasma. Others will need renal or hepatic metabolism and how it gets out of the body. So when you're looking at the drug, you're going to look at the person's body, how strong it is, how all these other parts, all these other aspects of their pharmacokinetics are behaving when you're picking a drug. But then also you're looking at what this drug does to the body, which receptors does it go to, and which receptors are you targeting for this patient, and what abnormalities could these receptors be having. So every time you think about a drug, you look at all these two arms for those patients. So there's something that we call context-sensitive half-life. Okay. Don't know if anyone has come across it, but I saw there's someone who had a name. I will pick you again. Context sensitive. Hello. Mulunji?
I think the context sensitive effect, I wouldn't be having a very good idea.
Don't worry that I'm overpicking you. I'm getting someone else to pick.
All right. Okay. For the context sensitive effect, I think it relate to how long the drug may probably once infused inside. That's what I would understand. Once infused inside or used for sedation, how long
Okay.
it may in the body and probably how long it may stay in the body and also how much time it may take to begin working or acting.
Okay. Someone called Elvis Tamale. Can you explain for us what you see in this graph and which drug you would want to pick? Which drug you would choose to use given what you're seeing on the graph and given what Mulonje has explained for us? Elvis, unmute yourself.
Yes, good morning, doctor.
Good morning.
Yes, firstly, I have some network issues. I didn't hear what Jonathan explained.
Okay. And then
Yes.
fine. The person called Kakoza Tamale, I think you need to stop being the host because I think you took on the host role. Come here. I need you to give up the host role so that I can be able to control better. Anyway, so what he explained for us this. I believe you understand what it is.
Explain again.
Explain which drug you would use.
For
Based on
particular,
what? For sedation, you're using it for a
sedation.
long time as an infusion, or you have a long procedure in theater.
Yes, to sedate a patient.
Looking
If
at
it's
it's a prolonged sedation, so you can see you have an infusion in hours, and you have a context-sensitive half-life for all these different drugs.
Okay, I think for sedation, I might use thiopento or midazolam. Reason being, I'm seeing that basing on the context sensitive. Okay, let's go which is going up. And in relation to the infusion duration, it will take a shorter time. That means in case I want to jump in for the surgery as fast as possible, then also it will take the time that probably it may take to act to be shorter compared probably to etomidate. So I might consider thiopento or midazolam in my view, but I think.
Okay. So when you look at this graph, it has your infusion in hours and your context sensitive half-life, which as Molunji explained, it's how much time, it's half-life is how much time your drug takes before you have half the concentration. So context sensitive is really within the context of an infusion. So usually if it's a short duration, maybe 20, 30 minutes, not so much of an effect for most of these drugs, except for diazepam, which is long acting. But once you start to push to more than an hour, you see that you're going to have to take a longer time. So if you look at this duration, as long as you have there's someone who needs to mute themselves. So if you look at, as you go beyond 1 hour of an infusion for most of these drugs, if you look at thiopento, you have a longer time over which your drug spends within the plasma before it's actually out, compared to drugs like etomidate and propofol. Something like propofol barely changes throughout, while ketamine after some hours will also have the same effect. Midazolam for this also the same effect, and etomidate barely changes, though it is rarely used, and I'll expect an answer much later. Okay, feel free to ask questions along the way.
Yes, doctor, I have a question.
Yes,
I
please.
failed to understand that previous graph, context sensitive. So, like thiopento means that for it takes longer in the body, even though you infuse it for a short time.
For a short time.
Unlike
So,
unlike propofol and ketamine, which
yes,
get done very fast, so it's better we use thiopento.
it's better you use
I
a
don't know if
drug
I
that comes out much faster. Because when you sedate a patient, right now we are looking at if you have a faster recovery, you're looking at drugs that you want to whose effect you want to get out of the system much faster. You don't want a drug where you're going to take 3 days before the patient is actually fully awake for you to assess. That's for faster recovery. Okay. And remember the first graph that we looked at that was talking about the pharmacodynamics, the pharmacokinetics. The drug is administered, it's absorbed, goes to the brain and acts, and then it goes and it's reabsorbed. So if a drug is very lipophilic, where does it end up?
brain.
Lipophilic drugs, after redistribution, where does it end up?
The fat.
Okay. So very lipophilic drug. How good is blood supply to fat?
Poor blood supply. So it takes
Okay.
longer in
So
the
if
body.
it's to get out, so that's what happens. So by the time all the thiopento is out of your fat and broken down in the liver and out of your system, it's going to be a much longer time because of that.
Okay,
Is that clear now?
yes.
Yeah. So it's about fat absorption for all of these and metabolism. Okay, so we've looked at what these drugs are like. When we're looking at an anesthetic, you want something that's going to be able to give you anesthesia, analgesia, if you can get amnesia as well. Okay. But then you also want something that has a good side effect profile. And we can only talk about the ideals that exist. But you want one drug that has all the characteristics, unless one of you is going to invent for us one, but we do not have an ideal anesthetic. And these are some of the physical properties. So things like pain are common with some. You want something that will notify you if you inject it into an artery. So more irritation, something that's affordable or cost effective, and that's something that's also stable in different environments, or more stable over a good range of temperatures. Then you also want to look at the pharmacokinetics and the pharmacodynamics. So you want something that's going to be fast onset. That's what we look at, the brain circulation. So from the time you give it into the vein that you're giving it through to the time it reaches the brain. And then redistribution to vessel-rich tissues as opposed to vessel-poor tissues, because that will give you a faster onset and offset, then clearance as well. And you don't want active metabolites, which will give you a more prolonged action. Then find something that has a good side effect profile. So things like emetic effects you don't want, involuntary actions, you don't want the hallucinations from some of the drugs. Then safe to use in most of the patients, if not all of them. So a few examples. When you look at the IV anesthetics, these are the two major receptors that you're going to hear about. Then there are two other drug classes whose receptors are different, but the bigger class falls under the GABA receptor, or they work at the GABA A receptors, and what they do is potentiate the GABA neurotransmitter, and that leads to inhibition of the brain firing. So they bind at different sites, not at the GABA, where the GABA neurotransmitter binds, so that they cause increased influx of chloride ions so that you have hyperpolarization. That's basically what it does. So it's the GABA receptors, it potentiates it differently, okay? Well, for the new neuraminidase deaspartate receptors, which is really NMDA receptors, it's only one drug that falls under this. So what you need with this one, because those receptors with this neurotransmitter, you have excitation, you need something that's going to be an antagonist at this receptor. So those are the two main classes or major receptors that you're going to look at. So looking at a few examples for the receptors, you have these drugs acting there. You have thiopental, you have propofol, you have midazolam and etomidate. Okay. Hopefully when you come to OR, you should be able to see them. If you ask for them, if you don't, you won't see them. And look at which patient gets what. The other two drugs, ketamine, works at the NMDA receptor, while dexmedetomidine works at a different receptor. You'll tell me which class it falls under. So thiopental still works at the GABA receptor. It's a barbiturate. It works as an agonist. And what happens? So what happens with it is that it increases the duration of opening of this receptor so that you have a prolonged action of your GABA receptor, of your GABA neurotransmitter. The upside of it is that it decreases your cerebral metabolic rate for oxygen. So if you have a patient in whom you don't want that metabolic rate to be high, for instance, which patients, Annette, which kind of patient do you not want a high cerebral metabolic rate? Annette. We can't hear you. Annette, we can't hear you. Arinda.
I can hear patients, but I think maybe patients who seizure patients.
Seizure patients? Not really. If I came in and you had a child with who is hyperpyrexic and they were seizing, is that a worry for them? Which patients are you really, really concerned about? Which patients are you really concerned about? The person I see raised hand. Someone raised a hand. I can't. Jonathan.
So I think I would imagine.
It's okay. Jonathan.
So I was saying probably the person who could have had a rotavic accident and could have had like probably an epidural hematoma, so probably a bit of a brain damage. So I would think that they wouldn't want a drug which would be increasing the cerebral metabolic rate. You would want something that might, I think, decrease the cerebral metabolic rate.
Okay. Yes. So patients in whom you have a raised intracranial pressure would be the type you don't want to have that. So TBI, any patient who has a raised intracranial pressure. Then also the seizing patients, you quantify it, not every seizing patient. It's usually going to be patients who are in status epilepticus. That's where we're going to put it. So you usually find it, you have an induced coma for those patients in the ICU. The downside of it is the hemodynamic instability that it causes, and then you're going to have respiratory depression. So if you're going to give it as an infusion, you're obviously going to have to ventilate your patients, or you should be able to anticipate an airway emergency if you give it to a patient. Then the downside, any patient who has porphyria will have an acute exacerbation if it's given to them. Okay.
What about a patient with a stroke?
What about them?
Is it necessary to avoid the high metabolic rate for oxygen in their brain?
It depends on where they are. So it's really those who are tending towards the how can I call it? Towards a raised ICP, where you're going to give them that. But there's the other thing that you can do with them is really, if you want to reduce their cerebral metabolic rate, you're just going to sedate them with other, are going to be to enable you to do a better neurologic prognostication. Because as you see with thiopentol, when we started at the beginning, your context sensitive half-life is not the best. So usually you want to leave it at the bottom of your list of sedatives for stroke patients. So you can use it in them. The challenge is that context sensitive half-life. So if you need to do a neurologic evaluation in the mornings, you won't be able to have an accurate one, especially if someone has had a prolonged infusion. Are we clear there?
Yes, thank you.
Okay. So the other drug that's there is propofol. It's an aqueous emulsion. So you have soya, a bit of eggs in it, and then triglycerides in it. It's short acting. It has a rapid onset. Even after a prolonged infusion, that's why people prefer to use it, or you'll find it commonly being used. It also helps with, it blunts the airway reflexes. That's the upside of it. The challenge with it is the depression. So if you blunt airway reflexes in a patient with a difficult airway, or in a scenario where you're not able to manage the airway, that's the downside of it. The other advantage of it is the decreased cerebral blood flow, which will obviously lead to decreased pressures within the brain and help with your ICP. So that will be good with your patients who are having a raised intracranial pressure for whatever reason. And because you have a very good, have a short context sensitive half-life, it's also good for those prolonged procedures or sedation in ICU. Metabolism is the liver, and then we know excretion. The challenge with it, you have a severe, it usually causes significant hemodynamic, which you should be cautious about in all your patients with neurological issues or who have traumatic brain injury and the like, or you have a patient who already has cardiovascular issues. Then also after prolonged infusion, you have what we call a propofol infusion syndrome. So you have, because it's made of triglycerides, you have an increased amount that is greater than what the liver is able to metabolize. You end up with things like acidosis, and then an increased level of your triglycerides, which gives you effects, and you can have things like cardiovascular collapse eventually. So you need to be cautious and know what range of your infusion to set and for how long. So that's a down using it, despite it being a good drug to use. Etomidate seems like the darling of all of them, because it's good for your patients who are coming in, for your cardiac patients for whom you don't want any hemodynamic instability, or any patient who is already hemodynamically unstable. It's what you want to use for them, because it does not have any impact, or it has minimal, if any, on the hemodynamics. So you'll basically remain stable. It's also a GABA agonist. So all the drugs I've been talking about are GABA agonists. You have a rapid onset, and you also have a rapid recovery. The downside is the involuntary movements that could freak anyone out. It causes a transient adrenocortical. That's the downside to it. So people are wary about using it for patients who already have who have adrenal suppression. And then the post-op nausea and vomiting, it's painful on injection, just like propofol, and gives you a thrombophlebitis. So the other drug that's used for induction, so you'll find the benzodiazepines, the most commonly used one is midazolam because of it's faster, it's short acting, it has a shorter duration, and patient is able to recover. Of all the drugs, it's the only one that is able to give you amnesia. Of all the GABA agonists, it's the only one that is able to give you the amnesia that you want. The difference between it and all the other GABA agonists is for it increases the frequency, number of times that GABA receptor opens. So with it also causes respiratory depression. Hypotension is not so much. Yes, and as you see, it's if you titrate it adequately, you should be able to give your patient. It has no analgesic properties like all the other medications. And then you want to use with caution in these patients because of their excretion. So ketamine is one that works at the NMDA receptor, if we all recall. It causes the dissociative anesthesia. So the patient looks like they are actually present, eyes are open, but they are disconnected from their current environment, which is good for many patients because you don't want a patient to recall some of the events of the procedure. The downside to it is it causes hallucinations, which many people don't, which is not really nice for the patient. It also has analgesic properties in addition to the sedative properties, and it can also be used on induction. The other upside is that it has a sympathomimetic effect. So you have a patient who is already hypotensive and hemodynamically unstable. They should be able, it's a drug you want to use in them. And then if you have asthmatics, you can also give it as an infusion because it has causes bronchial smooth muscle relaxation. Then you can also use it for sedation in the ICU, even for head injury patients. If any of you have read, you've probably come across older studies that say it causes a transient increase in the intracranial pressure, but the increase is not significant. So you can actually use it for sedation, at sedation, even in the ICU, or even in patients with status epilepticus, you can use it. The other upside to it is that it doesn't depress the respiratory system. So the patient will still continue to breathe despite that. Then with it, you have hallucinations and emergence delirium, and then hypersecretions, which you can control by giving an anti-cyanogogue. There is a question about its potential for neurotoxicity, mainly in the developing, mainly in infants. So the other class of drugs that are commonly used, they're usually used in conjunction with the other drugs. They might have a bit of a sedative effect, but it's mainly for analgesia, because when you're giving anesthesia, you want to have something that will give you analgesia, the anesthesia itself, and amnesic properties. So the opioids are mainly used to give an anesthesia, to provide the analgesic benefit, so they might have a bit of sedative effects. And most commonly what we'll use are morphine, fentanyl, morphine, fentanyl, pethidine, things like safentanil you might find depending on when the point at which you rotate. So for opioids, what you need to know still is the class of which receptor it acts at, the effect it has. Those ones you're going to look them up yourselves. Which class at the class at which the class of receptors, the effects, the side effect profile, which patient gets what, and which one you want to give at what point. So some of them will give you in retention, like intrathecal morphine, which you should be able to see, and then a potential for dependence and tolerance. Then significant respiratory depression in almost all the patients. Some of the drugs that we have looked at, except some of the drugs that we have looked at, except the opioids. So looking at those drugs, you just want to look at which properties you want for which patient, and then you pick and sort of create each drug fits. So just a few cases. So you have a patient who has coming in for myomectomy, and they say they are not going to get a spinal anesthetic. Frederick Kabigaba, what do you want to give them? They say they want to have a general anesthetic. Frederick, unmute yourself and tell us what you want to give this patient.
For me, I would give etomidate.
Why?
Thiopentol.
Thiopentol?
Yes.
Thiopentol, why?
Because it is going direct in the brain to act on the GABA receptors.
Okay, so the others don't go to the GABA receptors? Kisache Agi, do you agree? What drug do you want to give? Do you agree with? Do you agree with the Vigaba? Kisache.
So,
Pardon? I can't hear you. We cannot hear you. Okay, Mercy Kobusinje.
I would give etomidate because of good hemodynamic stability, given the fact that this is a failure patient.
Okay. All right. Yes, so you want you don't want to tip this patient at all. So you want to give them that. And then a child who has confirmed porphyria, they're going to obviously get to sleep. Which drug do you not want to give? Godfrey. Godfrey? Pardon? We can't hear you. We can't hear you, Richard.
Yes, doctor. Good
Yes,
morning.
please. Good morning.
Yes,
Which drug do you
for
want
me,
to give?
yes. So for me, in this so for me, I think I would give thiopento in this patient. I wouldn't give thiopento in this patient
I
because we
was
said that
wondering.
for it, yes, we wouldn't give thiopento because it exacerbates a patient like a patient with what? With porphyria in this
Okay,
case.
fine. So, okay. So I'll go back to our patients, the ones that we had. So review Mr. Tibbs again. He has an IO, he requires an emergency laparotomy. Requires an emergency laparotomy. Is someone who has someone who named themselves drained at 11 a.m. Kindly unmute yourself and tell us what you would give Mr. Tibbs. Drained at 11 at 8:11. What would you give Mr. Tibbs? What drug do you want to give him to sedate him? Sorry, for his anesthetic. You're giving him Magena. Then if you're not on, who is called no entry beyond 8 a.m. Kindly put your microphone close to.
In that patient.
Pardon? You'd give what?
I would give thiopento to that.
To Mr. Tibbs.
Thiopento.
Why? To Mr. Tibbs? This patient with hernia,
Because,
with an intra,
yes.
with IO? Why would you give him thiopento?
Yes, because I would want to use the anesthesia
as fast as possible. What's the downside of giving him thiopento? What's the downside of giving him thiopento?
hemodynamic instability.
So do you still want to give him thiopento?
If just have the situation whether so I would just give him thiopento.
You're breaking. I didn't hear you that clearly. You're breaking.
Yeah, that's why I'm saying that after doing the baseline investigation like CBC and I find that he's hemodynamically stable, I would proceed and give him a
Does a CBC show us hemodynamic stability? No, but Neville. I see you say you want to give propofol. Why do you want to give propofol?
There are bananas. I think there's something to eat in the house at least.
to answer? No, but okay, Sylvia.
Yes, Dr. I would agree with no, but I would give because of its rapid act seconds. And since I think it would work best for us.
Propofol.
Yes.
You're agreeing with Norbert. Norbert has left your group that is saying propofol. He posted in the chat and told you it has significant hemodynamic stability. So you're probably, he has left you. So your patient with intestinal obstruction is really going to come in already in shock, or they're hypotensive. So you don't want to give them something that's going to tip them over. So you're either going to give etomidate, or even better still, give them which other drug? Negaga Josephine.
I think
Which other
ketamine
drug?
would also work.
Perfect. Ketamine would work.
I think ketamine.
Yes, ketamine would work really well in this case because it gives you that sympathomimetic effect and helps you maintain, and will also give you some analgesic properties in addition to that. Okay. Looking at the next patient that we had, the baby who requires a dressing change on the ward. Boy, John.
A baby who requires a dressing change on the ward would just require a slight sedation. And the best here would be analgesic dose for ketamine.
But why would you go for ketamine? Because all the others can be used for sedation. If you learn if you learn their pharmacology, you can use some of them for sedation. Why are you going for ketamine?
I would go for ketamine.
What are the extra
The reason being, it
Mhm.
has hemodynamic stability one,
The
hemodynamic
baby is
stability
already
one.
hemodynamic.
Yes,
The
so
baby
it
is
has
stable
a good analgesic.
hemodynamically, so it's not your worry. Okay.
Yes, two, it has
Which
analgesic effect.
Okay. What else?
Yes.
Anything else?
Then the other thing is that it is metabolism is also faster in children, so it will wear
Yeah, you're
off.
sure about that?
Okay.
It will wear off everywhere. Okay, what else? Yeah,
Yes, doctor.
whoever raised your hand, kindly unmute and speak. Yes.
Yes, doctor.
Richard, you had
Yes,
raised
so
your
for
hand.
me,
You can unmute
yes.
and speak. Mhm.
So I think the other thing is that for ketamine, our airway is also not affected, so the patient doesn't need to be maybe intubated, so they can maintain their respiration on their own, even when they're on ward.
Okay, yeah. So it's based, so those are the things you're looking at. You look at a drug, it has analgesic properties, your airway is safer, so it's easier for someone to administer it elsewhere. Okay, we have a few minutes to end this. So Mr. JB, what would you want to give him? Someone called Nameless. Nameless, unmute yourself and you. Are you available, Nameless? Patricia, what do you want to give Mr. JB? Just unmute yourself. Eh?
I would give propofol.
Propofol. Why would you go for propofol?
It reduces cerebral blood flow, so it's good for increased ICP.
What drug do you think would be better for him? Better than the propofol? What would be better for him than the propofol? Work okay, Israel.
Yes.
What would be better than the for this patient? B. I can't hear you. I don't know if you're speaking. What would be better for Mr. JB to run for? Anyone?
I think your pento could be a good drug because it will be decreasing the cerebral metabolic rate, of which we said earlier on that of course in the emergency craniotomy someone of course already has an increased ICP. So my view would be your pentel, I think.
Pento.
All right.
Okay, pento decreases your meta, the upside of it. I see. How does it mean it? What happens is it does. What I said is it does not cause respiratory depression, so that patient is still able to control their respiration. They'll still have hypersecretions, and they can end up having a laryngospasm. Okay. Yes. So the person who said it's when you say thiopento is it decreases the metabolic rate. So that's why thiopento is preferred to be used, and because of the anticonvulsant properties. Nambu Pauline, thiopento is not contraindicated in a raised ICP. It's actually what you want to use. The person who for baby Dunia, you will ask your friends. Okay, so the mechanically ventilated one, I'll leave that one to you. I'll send my email. I'll put my email address in the chat, and then you can send questions. This assignment, the other drug which falls here is an alpha-2 agonist, which is dexmedetomidine. So that one you will go and read it up. And then so that's basically it, unless you have any questions. We should be ending this class soon. So my email address is there. Mulunji Jonathan, yes, please.
Yes, thank you so much, Dr. Rachel. So my question is in relation to an emergency surgery which can be done on an emergency ward. Can we still use midazolam, because I've seen it being used once in a while other than the ketamine? So can we
Which
still use
emergency surgery?
Let's say someone has had like a road traffic accident, and probably the arm is lacerated, but it has a deep cut. and might need to be sutured, but who might imagine probably this patient may be in too much pain and might need something stronger than liquid ibuprofen. So my question would be, can we still use midazolam in such a situation, or we can only stick to ketamine and the lignocaine kind of things?
So you realize midazolam has absolutely no analgesic properties.
Yeah.
Yes. So you cannot give only midazolam. You want to usually combine the midazolam, you give it with a ketamine so that you're able to blunt those hallucinative effects. Then the ketamine is there for analgesia and sedation as well. So what you'd want to do in such a patient is give other modalities of pain management. So you could add an opioid, maybe you could add an NSAID, paracetamol, give a regional block, and then they should be able to be comfortable. So it's getting all the other drugs and getting the benefits of all of them. Okay,
then
I see. Yes, please.
Just one question, doctor. I've heard in theater someone saying jungle juice or something like that. I'm forgetting what it was, but it's like a combination of analgesic drug. I don't know. Do you mind helping
Jungle
us?
juice is lidocaine and epinephrine, which is not in the scope of this. It's a local anesthetic with that. So
Thank you so much.
All right. I saw 2 hands raised. Are they down? Just unmute yourself. About to end the meeting. Or it's about to automatically end. Just unmute yourselves. Whoever has a question.
Yes, doctor.
Yes,
Thank you
please.
for the presentation. My question is on the part of baby junior. You said we use ketamine. I was wondering why did we dwell more on? Why didn't we go in detail on about opioids being used for sedation? And because I've ever been on theater, there was a lady was having removing a tumor from her breast, and she under anesthesia, but they used the pethidine.
She was under anesthesia, under general anesthesia?
Yes, it's pethidine.
The pethidine was being given for pain.
And okay, my second question is, why did we use morphine for the baby with
Morphine?
band? Yes.
To do what?
For the baby
Why don't
with
you use
band.
morphine?
Yes. So when we're going to dress that baby, that case.
What's the downside? What are you fearing with opioids in mainly children or extremes of age? What do you fear with opioids?
Opioids, I know they decrease motility.
What else? Motility, you may not be worried. Like you give them and you'll say, okay, they'll not pass till tomorrow morning. I will still go to my bed and sleep. But you've given a patient opioids now, and you're worried about going home.
Doctor, for me, I was thinking you'll be worried of respiratory depression.
Yes, so that's your worry. It's respiratory depression. That's your worry with using the opioid. It can be given in a controlled environment, but it can cause respiratory depression. That's why. Okay, I see. So, Paddy, are you sorted? Mr. Paddy?
Yes, I'm
because your
sorted,
hand is
doctor.
still up. Okay. Joseph Muwonge, your hand is still up.
Thank you so much, Doctor, for the lecture.
Okay. You're welcome.
You said some of the side effects of ketamine. We have excessive secretions, hallucinations, delirium. Then you mentioned some drug to control the secretions. I beg your pardon about that drug.
It's a group of drugs that are called anticyalogogues. So examples of those drugs are, that one will be your assignment. Look for drugs that have anticyalogogue properties. Okay?
Yes, doctor.
Yes. So those group of drugs are the ones that we give for secretions, to help with the secretions. Okay, Abraham.
Yeah, thank you, doctor.
Okay.
Yes, initially you had said hyopental is not given in patients with increased ICP. So I don't know why you said could
No, I did not say that one.
Oh, you didn't
You
say that.
probably
Okay.
heard me wrong. No.
Okay, good. My friend, my friend, we got it wrong and we are sorry.
He's a German boy.
Okay, no entry beyond 8 a.m. Your hand is up.
Yeah, doctor, me, I was inquiring. Yes, I was inquiring about the deadline for the appointment.
That one you're going to give yourself. I know when I'll ask for it.
Okay.
Yes. Tamuhimbi, sir, your hand is raised.
Doctor, thank you for the lecture. Me, doctor, I'm inviting anybody who can make it to the Sheni for Idi Aloha.
Wow. It's okay. You've chosen lockdown to ask for it. Can use courier services. Any other questions? Any other questions? If you don't have any other questions, we should be good to go. So you'll do the alpha 2 agonists, but for any drug, as we conclude, get the drug, know where it acts, its mechanism of action, where it can be applied, and then the side effect profile. Then you scratch your head in that direction. Yeah. Okay. So if you don't have any other questions, that's it for me. I see a hand up from someone whose hand is up. Just unmute yourself. Senkai Stephen. Your hand is up.
What's the assignment about? I beg your pardon on the assignment.
You're going to look up alpha 2 agonists. If you don't have any other questions, we're done.
Doctor, excuse me, doctor. The doctor please turn on her video so at the end of the lecture. To know
Can't hear
you. Doctor, you promised to turn on the video at the end of
You will see me in theater. Have a good day.